Rheumatology is a field that it's a study of different arthritis conditions. Not a lot of people know this, but there are over 100 different causes of arthritis conditions. Most commonly would be degenerative arthritis as we get older, such as osteoarthritis. But there are also inflammatory types of arthritis, such as rheumatoid arthritis, lupus, gout, bone health, issues like osteoporosis, osteopenia are dealt with rheumatology. The difference between rheumatologists and orthopedic surgeons are that we don't operate. We don't replace hips, we don't replace knees. Those are the orthopedic doctors. But we deal with arthritis condition in a non-surgical way. And this day and age, for inflammatory arthritis, like rheumatoid arthritis, we have available to us a whole slew of biologic options that we can use to get these patients into remission. Whereas previously, a lot of these patients with rheumatoid arthritis ended up with deformities, needing wheelchairs. But nowadays, we don't really see patients progress to that degree anymore because of the availability of all of these biologic agents. Rheumatology, pretty much focuses on managing inflammatory arthritis conditions. We also manage osteoarthritis, and that's where there's a lot of similarities with the orthopedic doctors. We can refer patients for physical therapy. We discuss lifestyle changes, diet, exercise, weight loss to manage their osteoarthritis in their knee. We can perform injections into the knee of either corticosteroids or hyaluronic agents to lubricate the knee. But as the osteoarthritis progresses, as a patient gets older, with more wear and tear over time, as that joint reaches end stage where all conservative treatment and pharmacological therapy is no longer effective and the patient is suffering, that's when the orthopedic doctor would kind of take over and proceed with discussing surgical options to replace the knee. So that's really the difference. We both can manage osteoarthritis, but it depends on, as it gets to end stage, that's where the orthopedic doctor takes them to the OR and replaces the joint. Rheumatologists, we focus more on the rheumatoid arthritis and lupus. Orthopedic doctors don't use biologic therapies. There's not in their training to use immunosuppressants and biologic therapy. So we see them kind of like as the surgeon who actually does the procedure to replace a joint. So we work very closely with them. Our rheumatoid arthritis patients, when they get to have end-stage arthritis in their knee, they are referred to our colleagues in orthopedics to have the knee replaced. And if a orthopedic doctor sees a patient early on who is referred to them and suspects rheumatoid arthritis, then they would refer that patient to a rheumatologist to help manage that patient. So we have a close relationship that we work with the orthopedic doctors. When we talk about bone, we have to remember that bone is a living tissue. There are cells in the bone that form the bone, and there are cells in the bones called osteoclasts that break it down. So bone is always remodeling. We know you break a bone, it's not always broken, it will heal with time. And the reason it heals is because there's remodeling going on. It's a slow process where you have these osteoblasts, which are cells that form bone, and then there's a balance between the osteoclasts that resorb the bone. So it's a very dynamic process, and bone density typically peaks, when we're in our 30s. Bone then starts to gradually degrade over time from aging, from decreased estrogen after menopause. So once the bone density is at its highest, throughout the rest of our lives, we can be at increased risk for sustaining fractures. The architecture of bone, there is the cortex, which is the more solid structure. And more importantly, there's the trabeculae of the bone, which are the internal pillars that help to hold the bone together. So it has a very good tensile strength because of the trabeculae. And if you have thick trabeculae, it's kind of like pillars of a building. You have thick pillars, it's able to hold up the structure. But as those pillars start to shrink down and get resorbed, you can imagine any force on that can cause the bone to crack or to break. And that's what osteoporosis is. It's a process of, from aging or from genetic factors or from medications that we use, causes the bone trabeculae to get weaker, to get thinner, and there you have increased susceptibility to developing fractures. The important part is the bone trabeculae, which is the matrix, and then also the cortex. And you have cells of the osteoblasts and the osteoclasts in the bone. And the therapies that we will discuss, later regarding targeting these specific cells, and that's how we manage to treat osteoporosis, by targeting these specific cells to either function more or to function less. Typically in clinical practice, to diagnose osteoporosis, we do a bone density scan, which is a study similar to an X-ray, very low radiation, where the patient lays on the table and it measures the bone density in the spine and also in the hips. We cannot typically assess or diagnose osteoporosis by simply an X-ray. So we need to do either mostly as a bone density. CT scans, quantitative CT scans can also be done, but those offer higher radiation. And so the preferred choice that's used in clinical practice is by getting a bone density scan. And it is implied that if you have osteoporosis in either of those spots, it does not have to be osteoporosis in the spine and osteoporosis in the hip. It's or, because we look at the worst score. Whether your worst score is in your lumbar spine or your worst score is in your hip, based on that score, the diagnosis of osteoporosis is made. So that implies that you are at increased risk of fractures, in those two areas, because that's really most commonly where we see fractures. We see fractures typically in the lumbar spine, and we see hip fractures from patients who fall. Fractures in the shoulders, those things can happen as well, but measurements by DEXA scan are not performed on the shoulders. The areas like the shin and the tibia, these areas are not typically measured. There are a few of these satellite clinics that may measure osteoporosis in your heel to see if there's any decrease in bone density in your heel. These are quick weekend screenings that are done, from a truck, where patients don't need an appointment. But the only downside of that is not very accurate, and the results are not reliable. So if you get a screening test and find that you have osteoporosis in your heel, I recommend that be followed up by a traditional DEXA scan to get a more baseline measurement of whether or not you have osteoporosis or not. Osteoporosis typically happens later on in life, in women, typically after menopause, because estrogen plays an important role in keeping the bones healthy. Once the estrogen levels start to decrease, we start to see more osteoclastic activity, which is the resorption of bone. These are the cells that are responsible for resorbing the bone. Peak bone density occurs in our 30s. And then after that, we start to see a gradual decline. And osteoporosis happens in women, but it also happens in men as well. Typically for men, it happens later on in life. But the bone mass, as we get older, risk factors that come into play based on our lifestyle is if we have a bad diet, high in alcohol, patients who smoke, those patients have increased incidence of osteoporosis. Family history is very important. If your mother has osteoporosis with a history of multiple fractures, chances are you're going to be at higher risk for developing osteoporosis. There are some things that are out of your control, such as just ethnicity. We know that Asians and Caucasians have increased incidence of osteoporosis compared with Hispanics and African Americans, less incidence of osteoporosis. So genetic factors play a role. Other conditions that we are attributed with osteoporosis would include rheumatoid arthritis, medications such as patients who require long-term steroids. These patients We know that there's a detrimental effect on steroids on osteoporosis. Thyroid conditions can increase your risk of that, as well as certain malignancies such as multiple myeloma, can increase your risk of developing osteoporosis. Having a small skeletal frame, if you can put your fingers around your wrist and touch, very easily, having a small skeletal frame, what that means is you just have a thinner cortex and much more likelihood of developing a fragility fracture later on. Lack of exercise, lack of calcium intake, lack of vitamin D intake, those are all very important things that can be controlled. So we always advise patients to optimize their calcium and vitamin D intake and to get plenty of weight-bearing exercises. Simply walking is all you need to do. 30 minutes of walking a day is enough to continue to put stress on the bone so that it continues to remodel. Astronauts that go out into space for a year at a time in the International Space Station come back to Earth with osteopenia and osteoporosis, just because you don't have gravity to remodel the trabeculae and the microarchitecture of the bone. With gravity and with these weight-bearing exercises, what you're doing is you're applying pressure on this live tissue, on this bone structure. And when you apply that pressure, the cells in the bone sense that it needs to keep itself in that same structure. Otherwise, you have increased osteoclastic activity, which leads to bone resorption.